All right, thank you very much. Well, welcome. And thank you for attending tonight's online GP focus group, which is part of the evaluation of the Canberra Maternity Options Service. My name is Michelle Tenius. I'm the Midwifery Advisor for the ACT Chief Nurse and Midwifery Office. Firstly, I'd like to acknowledge the traditional custodians of the land we're meeting on, the Ngunnawal people, and I wish to acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. So just to give you a little bit of a background, the ACT Chief Nursing and Midwifery Office is supporting the independent evaluation of the Canberra Maternity Options Service. The external evaluation team is being led by Professor Carolyn Homer from the Burnet Institute from Melbourne. So thank you, welcome Carolyn. Canberra Maternity Options Service commenced in September 2019 and was designed to be a single point of access to public maternity services in the ACT. The key objectives were to deliver early access to maternity care, to provide women with information about the different public maternity care options in the ACT. The evaluation will involve engagement and feedback from key stakeholders, including consumers, general practitioners, Canberra Maternity Options Service staff, and the staff from the 2 ACT public maternity units. Also, we're collecting data and previous consumer feedback, and that will be included in the evaluation. All this feedback will then be gathered through the evaluation process, will be de-identified and collated to form part of a final report, and this will be used to inform recommendations regarding the service for the future. Before I introduce the team from the Burnet Institute, just some housekeeping. So if everyone could just remain on mute unless you're talking, would be great. If you're wanting to talk or speak, if you could just raise your hand, which I know a few people have already worked out the button, which is great. We can also utilise the chat section on this Zoom meeting. We are recording tonight's event, and this is really solely for the Burnet Institute, so to ensure that everything that has been said has been captured. At the end of the event, you'll be emailed an anonymous online survey that you can complete if you feel that there is more that you'd like to say about Canberra Maternity Options Service that you haven't said tonight. And for those who could not attend tonight, an online survey will be available through the Capital Health Network e-newsletter next week. So now I will now leave you with Professor Carolyn Homer and qualitative researcher Sabra Turkamani from the Burnet Institute to lead the focus group. Thank you so much.
Thanks very much, Michelle. See you later.
Thank you.
Welcome everybody. Thank you so much for joining us this evening. We have just under an hour together. As Michelle said, I'm Caroline Homer. I'm a co-program director of maternal, child and adolescent health at the Burnet Institute, and Sabra is a research officer with us at the Burnet Institute, and we've been asked to do this evaluation, as Michelle said. So today we met with the team at the Canberra Maternity Options Service. Tomorrow we're going to Calvary, and on Friday we're going to Centenary Hospital. And we've also put out surveys for women, survey for GPs, and this session this evening. So essentially the aim of this evening is to find out your views, essentially on what parts of CMOS are working well for you, from your perspective, what parts of CMOS are problematic or are not working well, and what you would like to see change for the future. And obviously, your views are really important given the really critical role you have in primary care in the ACT. So it's a bit weird, I can't see any of you, so I can't ask you to wave your hands, but really happy to go around. I don't know if that's the easiest way to do it, or if people want to jump in and start us off, and I'll try and direct traffic. If you put your hands up, we'll try and keep an eye, but maybe someone like to start about whether it's working well and how. Tracy, thank you. Start us off.
So I'm Tracy Baker. I'm a GP. I've been a GP in Canberra for 35 years, and I'm very passionate about antenatal care as part of general practice and part of the continuity of care we provide. And I'm also the GP representative on the Capital Health Network for Maternity Services, ACT, and I've expressed my concerns to many well, in many fora, really, about what I perceive as the declining role of GPs in antenatal care. So, you know, by definition, GPs are cradle to grave primary carers. And for me, that includes antenatal care. And over the 30 years I've been a GP in Canberra, I've seen the decline of shared antenatal care. And I really lament that. I think it is a lack of continuity of care for our patients. I think we have an enormous amount of information on our long-term patients. I think we can contribute an enormous amount in terms of knowing their background. And I am really despondent about the lack of promotion of shared antenatal care in the ACT as compared to other jurisdictions where it seems to be very strongly promoted. And I'm also concerned about the anecdotal evidence we get from our patients which are many negative comments about the competence of GPs in terms of antenatal care and the care of the newborn. Many of our patients tell us that they've been told that GPs don't know much about pregnancy and they don't know much about looking after the newborn. We hear this time and time again. Our patients are surprised. And again, I, as a GP, I'm often seeing women who are in their 30s that I have seen since they were born. And they think I am actually quite competent. And I think this message that GPs should not be involved in antenatal care is so destructive to us as a profession. I have great concerns about it.
Great, thank you, Tracy. That's a really important place for us to start, I guess, around the messaging and the declining role of GP shared care. Anyone else want to jump in? And we'll come back to you, Tracy, I think, because you've obviously got a lot of advice in this aspect. Anyone else want to give some views on? Yes, Jess, thank you.
Hello, I was typing something in the chat and then I thought I may as well say it. My name's Jess Titterman. I'm a GP in Canberra. I currently work at Women's Health Service. I just wanted to say that I think that was really well articulated by Tracy, and I've been practicing shorter time and would say that even just in the last few years, I think I agree that sort of lack of involvement of GPs has been happening for some time, but I think there's been significant sort of loss of connection of GPs in the ACT with maternity services just in the last few years. And like Tracy, this is something that I know many others are the same, have raised in different contexts. And I remember, consultation a number of years ago now, trying to stress the importance of utilising the knowledge that GPs have for patients who then become pregnant or are planning pregnancy and connecting with maternity services. But it's like there's this disconnect. So I think that with the Maternity Options Service, I really recognise the benefit of having the ability for patients to self-refer people who might not otherwise know where to start. Or I look after a lot of women who are very disconnected from services and healthcare in general, and I think that's important. But I think it also, I don't think that should be at the expense of that connection with primary care. Like I don't think it should be instead of or the prioritised pathway. I guess, and I think that the challenge is that if people sort of skip straight into maternity services and there may be not, then some of those things about their pre-existing conditions or past history might not be considered as soon as they often need to be in the context of pregnancy. So yeah, I guess just sort of piggybacking on what Tracy said, and that I think, you know, I can see what the Maternity Options Service, what the goals are. And I think in some ways it has made it, you know, less complex to have a single kind of entry point.
Mm-hmm.
But I do think that it has perhaps unintentionally further or contributed to that disconnection of primary care in general from maternity services. And Tracy's right, in other areas it's very different. I think the ACT is a small jurisdiction and we should be able to have really strong connections of our GPs in this space with our perinatal care, but it's quite the opposite.
Yeah. Okay. Yeah, that's really interesting. I want to come back to you a bit later on about how we could make CMOS better, but I'll come back to that. Kathleen, thank you.
Thanks, Caroline. And look, I guess I just agree and support with what both Tracy and Jess have commented on. So look, I guess in terms of what's working well, I think it is useful to have a streamlined point of entry, because rather than trying to guess where we might be able to get our patients in. So there is absolutely advantage in that. And I think it certainly was a bit wobbly at the start and has improved a lot. One thing I would say is that I'm starting to notice that like the entire health profession, the midwives in this team are feeling a bit overwhelmed. And so there is a delay in patients getting seen. And I do apologise, I'm a bit of an example-based person, so often it sounds like just N=1. But, you know, recently I had a patient who's a moderately high-risk pregnancy, and she was distressed that she couldn't be directly seen in the antenatal clinic by the doctors, noting that she was not appropriate for midwifery care. And it was very difficult. And the concern for her was she couldn't get an appointment for quite some time, even with the midwives for the entry process. And so needed me to kind of assist facilitating fast tracking that. So there's little things like that, I suppose, but really what it does come down to is that exactly what the others have said is this disconnection between the GP, our role in advising or, you know, giving information about our patients and otherwise. And there are a few things such as, you know, these are just day-to-day frustrations, but I guess the most important one would be if our patients develop a complication in their pregnancy, for example, GDM requiring insulin, we are not informed. And it has been raised before, and that remains a great concern. We often have women come to us, just make an appointment and say, oh, the midwife said I had to come and get you to give me an iron infusion, with no pathology results, no correspondence, no kind of working together, just sort of almost treating us like a community intern, really. And the same with things like early on, there's a checklist of blood tests that you need to do. They're not necessarily evidence-based. For example, not all women need to have, you know, a hepatitis C test in the last 3 months, but we absolutely cannot get them into even past that first appointment without meeting this checklist. So they're small things, but I think what they signify is this just lack of kind of communication. We're really not getting any feedback to us as the GPs, but by the same token, I feel disempowered as a GP if I feel the midwife caring for my patient needs some information about them. I've got no practical way of contacting them. So it's that two-way street, because if I want to be communicated with, I feel I should provide that in turn, but I can't. So yeah, I feel a bit disenfranchised, I think is what I would say.
Kathleen, can I just ask you that the communication, the lack of communication, the example you gave about women who required insulin along the way. So is that communication that you're not getting from the hospital antenatal clinic, or communication originally from CMOS? I'm just trying to work out where the lack of communication.
Yeah, so to be honest, it's not clear because we don't always know, but I think probably a better example might be hypertension in pregnancy, where that's potentially being managed still under midwifery care. But all it is that if something's coming up and they're managing it, we're not informed. And I think it's probably raised before, and actually Tracy, you might be more aware of this, but you know, the feedback was, oh, we don't have time to write the GPs or whatever, and that may or may not be true. I mean, we're busy too, But honestly, like the NICU team use a pro forma with a checklist on it, and that's a completely appropriate way to communicate standard things. And I think most of us would be, well, I would be content with that. But I generally find out through my patient who's coming to get, you know, a certificate for being able to continue working, or something that, I mean, I don't know if they need me to do that. Really, I'm very happy to do it because it gives me a chance to catch up with them and see how they're going.
Yeah. Okay. Tracy, and then I'll go to maybe Chris.
Yes, I mean, my point is that if we don't get the communication, we don't know who's not communicating with us. And I think the other point is that once someone sees CMOS, we get a standard letter saying your patient has had their first CMOS appointment, but then we often don't get anything else ever.
So from the hospital.
Yes, yeah. Until we get the
discharge.
You know, your patient has had a baby type thing.
Yeah.
And for me as the GP, that leaves me uncertain about what model of care this patient is having and whether I am responsible. You sort of wake up at 2 o'clock in the morning and think, oh, you know, I haven't seen X and she must be 20 weeks pregnant by now. And I don't know who's looking after her. You know, what am I supposed to do? And I really think this, you know, there's a standard letter which says your patient has had their first CMOS appointment and they've expressed a preference for this model of care, but we don't get told which model of care they're being channeled into. And as I've said before, it's very rarely GP shared care. And you know, this point that Jess made about using the patient as the communication is totally unprofessional. I mean, it happens so often that the patient says, you know, the midwife said you haven't done X test. I mean, that is very unprofessional and it's also unsafe. It might seem paternalistic to say the patient cannot be a reliable informant, but it is not professional behaviour to use the patient as the mediator of medical information.
Sure. Okay, thank you. That explains that. That's very helpful. Chris, and then I'll go to Morag.
Hi, yeah, I sent through some comments which you might have got.
Yes.
So I guess my biggest concern, not so much with the model, but just purely looking at how they're working, I'm really concerned antenatal care is a time-sensitive, time-critical, you know, pregnancies, you know, critically time-sensitive. So, and we're missing best practice management, you know, by a mile, basically, by 2 months. Same reinforced communications critical. Need to get, you know, immediate confirmation of appointment. Patients need to be seen within 48 hours, probably within 5 working days. They should be seen physically and had a full visit. They need to be, you know, critically streamlined into which other high-risk patient streams. Access to GP care is not supported at all, same reinforce. During the pandemic, we did most of the face-to-face stuff. Unbelievable that they wouldn't see patients face-to-face. So weird stuff. Yeah, so this whole thing about, you know, preterm birth, aspirin therapy, et cetera, you know, best practice diabetes management, you know, it's absolutely critical time, you know, time sensitive. So you can't wait 8 weeks to have the first appointment. You know, if they want to, if this system wants to take on the mantle of antenatal care and be the primary point, they need to, you know, really pick the game up, and they need to be working very hard or very late, or I don't know what, but you know, they need to change. You can't wait 8 weeks to see you have the first visit. Yeah. Proposal: don't spend it. So instead of spending money on this model, any further funding, so fund GP access, and I'll put a little model there of, say, $100 voucher to, you know, a GP does a prolonged consult or does 3 prolonged consults, you know, perhaps 1 prenatal, 1 and 2 first trimester, and then perhaps another 1 third trimester. I've got a profound ethical dilemma about seeing low socioeconomic high-risk pregnancies, how you see them, how you charge. They don't get access generally very well, and they don't get much time. And it's a medical a lot of it's a medical assessment. The other way to do it is stick a midwife in the big general practices, having regular antenatal sessions. ACT Health fund that rather than more midwives. Have a system where we can access them quickly. And my last little bit was, what are the guidelines? We're not talking about the guidelines, how things are managed, 100 milligrams of aspirin, 150 milligrams of aspirin, what is the current, so regular GP meetings, 6 a year, planned in advance, funded GP attendance, funded midwife attendance. We thrash through this stuff. And all the, what are the protocols for preterm birth prevention? We're all working off different protocols. They're my big sort of beefs.
Yeah, thank you, Chris. I read your email this afternoon. Just on that, the GP shared care protocols, is there a protocol for GP shared care of who does what and when, and which, all of these sort of things that we've been talking about? Is there one for ACT Health? Yeah,
5 years ago, there was a great document. Nothing since the new guidelines were done by federal stuff.
Okay, so it's a...
Or health pathways. It's buried in health pathways somewhere. There are guidelines.
Right.
Everyone else want to comment on where they sit? Yeah.
Yes, Jess, again, that's something specific, and I don't know if Kirsty Douglas is in this meeting, but her and I attended a consultation. It must have been, could be back in 2017 or 18, where this came up, and we talked about the need to have, like there has been in the past, and there is in other states and territories or health, jurisdictions, a sort of clear guideline, work instruction for, as you say, what is whose responsibility and when, and like an anticipated schedule of visits for people who are having shared care with GPs, and I think that lack of framework in the ACT is a direct factor in why there are less and less GPs in this space, because I think we've talked about the ways that we've become disconnected and it's difficult to be involved in care. But I think it's also difficult for GPs in the community to know what's expected of them in providing shared care and to learn in that area. So I've also had conversations with GP Liaison Unit and Anne-Marie Svoboda and Capital Health Network about the need to have education and networking opportunities for GPs with Canberra Health Services maternity staff to make sure that we sort of foster those connections and share that knowledge. But there's just been a complete lack of that for a number of years. And I agree. I think that sort of framework line, ACT shared care policy is, probably a really important piece of work that just doesn't exist at the moment.
Okay, thank you. That's helpful. So I'm going to go to Melanie, and then I'm going to see if Morag can talk, because we've been trying to connect you, and then I'll go back to Tracy. So Melanie.
Yeah, I thought I could just give some background on that one, and Tracy can probably update it. So I was the GP clinical editor for Health Pathways that worked on the original antenatal pages, some of which have been updated and some have not. When we did that, we couldn't get a new GP shared care guideline because it was everyone just needs to follow the national ones. We couldn't get a sort of, expectation of who's the patient seeing for which visit, that there should be the 8-week visit with this and a 12-week visit and a 16-week visit. No, there was no interest in doing that. That's probably going back to 2016, 2017, I think. Maybe slightly earlier. And then, so the big gap in what was available. And then at the end of last year, I was acting as GP policy advisor, and the beginning of this year, acting as the director of the academic unit of general practice. And so in the meetings with Tracy, and again, we were raising this as an issue that we need to make sure we're working off the same guidelines, especially if we're being sent patients who apparently need their vitamin D done or their Hep C, and we're looking at them going, actually, it's not indicated, but that's what the hospital's insisting on. Some stuff I've given up on. And we were talking in these meetings about needing an outline. We need the framework. We need to all make sure we're on the same page. We need to even have information about how old can we accept blood tests. If we're doing, you know, appropriately pre-conception appointments and screenings, and then it takes someone 8 months to fall pregnant, how many of their bloods are going to be accepted? Are we going to need to repeat them all again? And that's something that I find frustrating these days, to know, you know, how much do I order ahead of time and what will we just have to order again? Not only is it frustrating for the patient, it's Medicare dollar as well.
Yeah.
So we talked about that, and Health Pathways got on board with wanting to do it, and they have not. I mean, it's difficult. There are complexities in terms of the O&G unit at the hospital at the moment, but they have not been able to get a subject matter expert from the hospital. And so there's a level of engagement from the specialists in leading this, because we do need an obstetrician to sort of lead the collaborative work. So it's not just us making up stuff, and well, not that we make up stuff, not us doing things what we think is appropriate and the midwives doing things the way they think it's appropriate. It really needs to be working together. But apart from knowing that Health Pathways a month ago were still looking for a subject matter expert, I don't know what's happened next. And I've just noticed that Tracy has dropped off.
Oh, she might, hopefully she can come back.
Hopefully she comes back,
Yeah, and I've seen Kathleen's defeat on a lot of those things, but yeah, no, look, absolutely agree. You can't do this without having a framework or a guideline or an understanding. It's just impossible.
And Caroline, I'm sorry to use the word defeat, but I almost like that's how it felt, because I was really trying to be responsible, and it's exactly what Mel was just describing. You know, I have a patient who'd had bloods done, I think it was 6 months before pregnancy. There were no new risk factors for HIV, syphilis, hepatitis, and we talked about it. Actually, she's a lovely woman. We talked about it, and I said, look, I won't do them, but there's a chance that you'll be sent back. And that's exactly what happened. She said, oh, guess what, you were right, that's what happened, they've sent me back. And it's like, yeah, so I guess one thing I say on that is I do wonder whether, because I know there are some processes in Canberra Health Services that are very protocol driven, and people may or may not have the discretion to work outside of those. And maybe that's what, you know, what Mel was sort of saying about having someone who has the authority to sort of say, no, that's appropriate, not to repeat it. And I guess, yeah, so that it is, it's discouraging. And I guess just while I've got the microphone, I just wanted to flag another thing that's challenging is, because the clinic I work at, the pathology lab in our building is a capital pathology building. So women, because it's more convenient, they'll often get their bloods done there. And whether they're unable to or unwilling to, we get told that no, they can't get bloods from capital pathology, send back, make you a GP. And that's the language that we get told. I was told to make you, you know, and so we're told to reset it. So as I said, I genuinely don't know whether it's something they are unable to or unwilling to access. But again, if the team could be supported to have access to the major pathology labs in Canberra, that would be very beneficial, because it's really not useful for the health system to be repeating that kind of work, given that we're all under pressure at the moment.
Yeah, absolutely. Thank you. All right, let's keep going around for people who haven't had an opportunity yet. Morag, is your microphone working yet? Do you want to jump in here at all? Maybe not. That's all right. Happy to take comments in the chat. Sharon, we haven't heard from you yet.
Hi, I'm the GP liaison officer at Canberra Hospital. Totally agree with the comments made by all the previous speakers. And I would probably have one thing to add that has come up only over the last couple of weeks, is the difficulty patients are having at actually getting through to the CMOS line to make that first contact. We've had patients who have been number 96 in the queue, number 61 in the queue. And I can certainly send you through a letter that was written by one of the doctors at Oka Health, Bruce, regarding that. It appears that the intake line has changed their processes. And I think that that's having a bit of an impact, because of course, if you hear that you're 96 in the queue, you're going to hang up.
Absolutely.
And they do say, if you select for a callback, you will maintain your space in the queue. Now that message is left at, I think, about 2 minutes, but you don't get the option to select option 1 until 4 minutes and 20 seconds. And I've measured, I've called it myself a couple of times, and those timings have been the same. So I just don't think people are going to hang on for even that 4 minutes and 20 seconds.
Yeah.
So we've had complaints that people have tried multiple times to get through to that line for their first appointment.
Yeah, and then they're not going to persist, are they? And then that's another delay.
Yeah.
Okay, thank you. Lynn, we haven't heard from you yet.
Hi, I work with Sharon in GP Liaison. So yeah, I'll agree with what she said. I guess I do have concerns around, I guess there's workload and workforce pressures in the delay in patients getting their initial appointment from when the referral gets in. I've had GPs and patients call that their referrals have been in for 6 and 8 weeks to CMOS, and they've had confirmation that the referral's been received, but they haven't had an appointment booked. And my understanding was always that CMOS was to facilitate that earlier management, earlier access to care through the hospital, or knowledge of what their care options are, so that they can, get those appointments. But obviously, if they're not being seen even by CMOS until 14 or 16 weeks or later, then you're looking at, 2, 4, 6 weeks longer before they're actually going to be seen at the hospital. And that's a big delay, and that's a worry.
Yeah, no, having a referral for 6 to 8 weeks but no appointment is not a speedy service at all.
No.
Yeah, thanks, Lynn. Anne-Marie, do you want to jump in here? You were first on and now we haven't heard from you. Sorry.
First on and last to speak. No, that's okay.
Not quite last.
Well, Carol and I don't quite know what more to say with all of that. I guess two things. I mean, I think the one good thing about CMOS, if we're going to break it down into CMOS versus the antenatal care and maternity care that happens after CMOS, if we think about CMOS, the good thing there is that there's just one place for us to remember to be able to refer people in. And I think that that's a good thing. And I've had good feedback from GPs about that process, whereas before we did have to remember all the different types of clinic and where to send people. So I think it's a good thing to have that central intake. But echoing what others have said, I think the communication back is, hugely missing when it comes to maternity care, and that's a major problem, and that does impact on patient care. It does impact, I think, as Tracy said too, on that relationship. We don't have a good relationship with the midwives, and they're not comfortable to call us, obviously, and it makes it very hard for us to know who to speak to as well. And we can all use busyness, we're all incredibly busy, but actually it's about having good clinical handover and movement of care between general practice and maternity services, and recognising the importance of that and what GPs can provide. So I think just getting that respectful engagement and understanding that it is important for GPs to have that information is critical to all of this. And Tracy's right, the patient shouldn't be the bearer of the information. That information should be, you know, in writing or by direct communication, and not via a patient where, you know, multiple things can go wrong.
Sure. That your comment about the relationship, I think, can I just sit on that for a minute? So forgive me, I'm used to other states, but in other states I've worked in, there's like a GP shared care training day or training evening once every 6 months or 12 months or something.
Yeah.
Does that happen in the ACT?
It's gone missing in action is what I would say, Carolyn, about that. So we did used to, COVID has got in the way of our education events. So we did have a big maternity services education event planned for May 2020, and of course that was the beginning of the pandemic, so that education event has been cancelled. And unfortunately, despite trying to re-engage with Capital Health Network as well as the maternity services, we haven't been able to get that back up and running, and I think it's vitally important that that does happen. Now, of course, at the moment in the hospital, you know, the teams have no capacity, I would say, at the moment, but, you know, it does need to be, that engagement does need to happen again. And I think it would be good to have a process where we have regular education events rather than just one event that happens, you know, over a whole day every 2 years. Yeah, what I'm hearing from the GPs is that they would like a program that is more regular.
Yeah. I mean, it also might be an opportunity to meet those midwives working in CMOS and kind of develop a relationship so that you could pick up the phone and ring someone, or they would feel they could pick up the phone and talk to you about a issue or a referral. Or I just think those relationships makes everything work a whole lot better. Morag, thank you for letting us know about Julie. I think I've seen her emails, so thank you. We've had 6 emails so far, and I'm really happy to receive them more. I'm just going to go to people who I haven't had a chance to hear from yet, and there's MZAHE, and I'm really sorry I can't say your name if that's your name, so forgive me. But I don't know if you want to jump in and say anything at this point. Maybe not. Okay. If you do, please feel free just to jump in. Tracy, I see you've come back, which is terrific. Is there anything you want to add?
Well, I was just mysteriously muted there for a while.
Yes, you disappeared.
Just getting back to a point, I was offline for a bit, but Melinda Choi, who's the GP advisor to ACT Health, and myself have developed a desktop GP guide to antenatal care, and we're hoping to have that approved by the Maternity Services Committee at the next meeting very soon, and then get that out to GPs. So the idea of that, in reference to one of the earlier comments, is to give us a bit of a cheat sheet in terms of what conditions to consider, what investigations to order, and what referrals to make. But again, if GP shared care is not encouraged, we will be de-skilled, and that will be a continuing problem. And in terms of even training our GP registrars, GP shared antenatal care is considered the core skill of GP registrars, and if it's not encouraged, those GPs in training will not develop those skills, and I think that's a really important lack in their medical education. But yes, we're trying to develop a desktop one-page guideline to antenatal care, which should be out and available through Capital Health Network and GP Liaison for distribution to GPs, and we hope that'll be being sent out within a month or so.
Great. Tracy, would that go to services like CMOS? So
no, no, it won't. It will be approved by CMOS. It will be for GPs, but trying to standardise care so that what CMOS is doing and what GPs are doing aligns with each other.
Okay, so but you'll be sharing it with CMOS so that they all do a lineup.
They have been asked to comment on it.
Okay, great.
And we've received comments and we think we've come up with the finalised version, which we just have to get signed off.
Okay. All right, so we've got about 10 minutes left. Any other kind of burning issues that you don't feel we've been able to explore yet about the way forward? We've certainly got lots of good suggestions. I think, you know, for me, hearing communication, relationships, supporting and promoting GP shared care, the GP training program, the guidelines, you know, recognising the role of GPs in antenatal care. And I think your comment just then, Tracy, about GP registrars, I think is really important.
I think the other point that has been raised over time is whether GPs who want to do shared care should be certified.
Ah, yes.
Now, in other jurisdictions, I understand there is some sort of certification process. And if you want to do shared care, you have to do a certain education standard.
Yeah.
And in the ACT, we haven't had that. But and I actually don't really see the necessity for that. I think GPs have an enormous interest in doing shared care, and we just are not being encouraged to do it. And
Right.
you know, I think there's a spiral here. You know, we're not being encouraged to do it. We lose our skills. Our registrars lose their skills, and so this perception that GPs can't do antenatal care is perpetuated. And I think that really needs to change, because it's a very core part of our care for patients, and it's a core part of GP training.
Yeah.
Caroline,
Yes.
I just had another point that I wanted to make about responsibility for pathology results and radiology results. One of the biggest risks I see for GPs is about ensuring that results are adequately followed up. And I do get anxious about what happens with the results that I send to CMOS. I mean, I do copy everything into maternity options, but of course there's no acknowledgement that that's ever received, because there's never any communication back. And I think it's not clear if you you know, if you do an ultrasound, or you're provided an ultrasound for somebody at the request of a midwife, you know, who's then going to take the responsibility for that. I will always follow up my own results, but there is a risk of things being lost in the system. And same when there's an abnormal result, and if somebody then sends it on, how do we, you know, how are we guaranteed and assured that you know, action is taken in a timely way, particularly when there's a, you know, critical result about an early ultrasound that might need on referral, for example, to the fetal medicine unit from CMOS.
Yeah, so that's a bit I've been trying to unravel a bit in my head, I must say, Anne-Marie. So if a woman goes to CMOS and she hasn't had all the things that she should have had at that point, so CMOS then says to her, go back to your GP and organise your ultrasound and your whatever bloods need to happen. But the CMOS midwives never see that woman again. She goes off into wherever the option is that she's chosen or has been recommended, or, you know, fits her risk criteria. So I can't imagine that they have a mechanism to follow up results, because that patient has now left them. So there is a gap there, because she hasn't really gone back to you.
And therein lies the problem, because where does the GP then send the result to ensure that that is appropriately dealt with in a timely way? And I think we haven't quite got that securely done. And you know, it's very dependent on the GP then knowing, oh, actually that might need to go to fetal medicine unit rather than through CMOS, and making sure that that referral does happen.
Yeah, no, that seems a bit of the cycle that's not quite joined up yet.
I'd be interested to hear what the other GPs who are online understand about that process.
Yeah, maybe Jess has got something to shed.
Yeah, I was going to say related to that is the sort of challenging issue of, I guess CMOS is almost built on this assumption that women don't know what, women and themselves and GPs don't know which model or specific service fits them best. And most of them do, you know, most of them have preference for identified comorbidities or you know, risks in the pregnancy. And so I do find CMOS particularly tricky to navigate when I've got a high risk person who I know needs to be with the fetal medicine unit. It feels like a bit of an extra redundant step when I've already done the relevant investigations and I've already assessed the risk for them then to go, you know, so that's a part of the system that I'm not sure about. And as you say, tying in with that, those investigations. So I've sort of then had, you know, where someone in FMU seems to have reviewed that referral or that information and says, yeah, they need X, Y, Z. And then they, you know, does that come back to you? I think that's for perhaps routine care or patients without risk, that's a bit more straightforward. But for women or people who need additional investigation earlier in the pregnancy, higher frequency of monitoring, or, you know, I think it does get quite complicated and unclear as to who's doing what, who's responsible for what. As Anne-Marie said, I also, if I ordered it, I'll follow it up. But how to do that when a patient is engaged with another service can be really difficult. Like if you know, you've got the result, you know what needs to happen, but how to perhaps make it happen or bring it to the attention of the relevant people.
Yeah, and talking to the CMOS service today, they put women on wait lists all over the place, and they can't, so women are not in a service yet. There's this sort of no person's land that they land in until the next lot pick them up. So I can see there's some gaps there. Kathleen.
Thanks, Caroline. I'm not quite sure if this comes in the scope of this evaluation, so apologies if not, but I just wanted to flag an issue about equity of access that I find that we get often due to lack of available resources in the public system. Many women, depending which model of care they're in, under some models of care, I think particularly the ones that are through Calvary, are sent to the GP, again, as a bit of an intern thing to get a private 20-week ultrasound. And again, just flagging back to the iron infusion issues, you know, they're just told to go and get their GP to give them an iron infusion. And that does raise a bit of an access issue, that not everyone will have the means to pay for those because they're not cheap services. So again, acknowledging that all services are under pressure. So for example, with the iron infusions, we'll have women sent to us told to have one who don't meet the hospital's own criteria for having an iron infusion, but they may not be able to afford it. So even if you did agree, it's very difficult to get access for them. So again, I'm not 100% sure if it comes in under this remit, but there is a bit of an access issue there because this is the public system, I suppose.
Yeah. Yeah, thank you. That sounds very complicated. All right, we're kind of running out of time. Anybody have any other issues they'd like to raise this evening? It's been super helpful, and really value your very thoughtful comments and suggestions. Melanie.
I've just had one thought with Kathleen commenting about equity of access and wondering, as I've just realised I don't know the answer to this, someone else here might, but otherwise it might be interesting for you to find out. If we have someone who finds out late that they're pregnant, you know, this is your equity thing, that if you're a, you know, middle-class woman planning a pregnancy, then chances are you'll get yourself into CMOS. You'll be calling them at 4 weeks. I actually had someone recently contact me to start the ball rolling. They weren't even 4 weeks pregnant yet. And it was just a bit interesting. If you've got someone who doesn't even find out they're pregnant until 18 weeks, 20 weeks, chances are they are a more vulnerable person. And the continuity of care options tend to get full early. I mean, it may be by that stage someone has, left due to another reason. They've not been able to continue in that option. But if it means that these more vulnerable women who have missed any early antenatal care potentially have chaotic lives, potentially not just unplanned, potentially unwanted pregnancy, how easy is it for them to actually get a lot of midwife support if they're coming through? Like, as a person in the community, you know to call this number potentially, or you find to call this number when you find out you're pregnant. I don't know how CMOS would handle it if someone tried to book in with them having no idea how pregnant they were, but just realizing that they were pregnant. But it just makes me wonder about access to the more specialized services if someone does come in late.
They certainly raised it today, Melanie, as a concern. They felt those particularly vulnerable women who potentially booking late or not booking at all, or were missing out on essential services, and were missing out on the models of care that were available. So I think that equity issue was certainly flagged today. That I can see it from your perspective as well. All right. Tracy, last word, and then I'm going to stop because I'm sure you've all had a long day and time to stop. But yes, Tracy.
Well, just a point about late presentation. I mean, being a member of this Maternity Services Committee, it's been very interesting to me that ACT Health collects data on a woman's first antenatal visit. And that is actually her first antenatal visit to CMOS. And it is not her first antenatal visit, because many of those women have had 2, 3, 4 visits to their GP. And apparently in the ACT, 50% of women don't have their first antenatal visit till 14 weeks, which we as GPs know is not true. And I think that's a reflection of the fact that our input to this system is not acknowledged, really. I mean, it's, just the data collection side of things is not a reflection of how GPs work and how much input we have into antenatal care in the first trimester.
Yeah, look, that's, I sit on some national committees around data, and that's been flagged a lot around, the messiness of measuring that first visit. And we place such a lot of emphasis on it in national data systems, but we don't actually measure it correctly. No, you're absolutely right. All right, thank you so much, everybody. Really, really appreciate your time on a cold Wednesday night. And we're going to write a report for ACT Health that we'll deliver to them in the next couple of months, because we have to let the surveys spend a bit of time out there before we close them. So I'm sure you will receive that report, all the recommendations in due course. So thank you so much, and hope you have a nice evening and a good week. Take care.
Thank you.
Thanks. Bye.
Everyone, have a good night. Bye.